Hi, I'm Debbie Levine. I'm the Senior Deputy Editor for Radiology, and I'm here today to introduce the February podcasts. And we really do have an extravaganza for the podcast today. We've got one podcast that was moderated by Dr. Kressel, who's the editor, of course, of Radiology. He's talking with Dr. Perry Pickhardt about the paper entitled Colorectal Polyps Missed at Optical Colonoscopy, Despite Prior Detection and Localization by CT Colonography. Then I have a group from Canada that I actually interviewed, and they were represented by Megan Prummel and Anna Chiarelli, and their paper is entitled Digital Compared to Screen Film Mammography, Measures of Diagnostic Accuracy Among Women Screened in the Ontario Breast Screening Program. And joining us for this discussion was Dr. Etta Pisano, who wrote an editorial to accompany that article. It's a very interesting discussion on film screen mammography. And then finally this month in February, we have our musculoskeletal deputy editor, Dr. Ali Gormazi, who is speaking to authors Dr. Roskopf from Zurich and Dr. Wu from Taiwan about elastography of the upper extremity. They're talking about the coracohumeral ligament and talking about the supraspinatus muscle. So I think you'll find these podcasts very interesting, and we hope you enjoy them.
Hi, this is Herb Kressel, and welcome to the Radiology Podcast. Today, I'm delighted to be joined by Dr. Perry Pickhardt, Professor of Radiology and Chief of Gastrointestinal Radiology at the University of Wisconsin. Welcome, Dr. Pickhardt.
Thanks. Pleasure to be here.
Dr. Pickhardt and his colleagues at the University of Wisconsin wrote a very provocative article entitled Colorectal Polyps Missed at Optical Colonoscopy Despite Prior Detection and Localization by CT Colonography. It's a very interesting title, and you certainly have a very, very interesting experience with CT colonography. Can you tell us a little bit about the CT colonography program at the University of Wisconsin?
Sure. So we've been in existence now as a screening program, a standalone program for over a decade now, really on the heels of the Department of Defense trial where we validated the modality for screening in general. And shortly after that, when I came to the University of Wisconsin, we were able to meet with the medical directors of all the major HMOs locally, and we're able to get coverage for screening. So that's been the unique aspect of our program, is that it's covered by most insurers here locally for our hospital only, really, and that's been the case now for going on 12 years here.
So how do patients learn about the program? Are you advertising? Are you having sort of seminars or reaching out to primary care doctors? What's the basic route of patients being referred for CT colonography?
Well, it was initially, it's a multi-pronged attack, but initially just the publicity related to the trial and the attention that received and the attention on the news that this is now a covered exam. But after that quickly faded away, it really took a lot of interaction, grand rounds, meeting, a lot of meet and greet sort of lunch meetings out at the clinics just to try to get all the primary care providers on board with this. It turns out they're the gatekeepers are really our primary care providers, the internists, the family practitioners, with the gastroenterologist really being a secondary role for the incomplete studies and less so for the screening exams. But having said that, we really need the gastroenterologists on board as they're really looked at as the keeper of the colon, so to speak. So I think our primary care providers really want to see their blessing, which we've had for quite some time.
So in Massachusetts, typically our primary care doctors would refer people for CT colonoscopy. So in your setting, the primary care doctors would make a determination or have a discussion with patients as to which they prefer, either to go the optical or the CT route. Is that correct?
That's right. And actually, we have data now that shows when patients are given that option, when they have the insurance coverage for both, that it actually is elevating all screening rates across the board, both for CTC and even for colonoscopy. So we think it's that discussion that's increasing adherence rates. That's hopefully going to be a future manuscript.
So in general, what percentage of those coming to your center are for screening versus for further evaluation of definite signs and symptoms?
Well, just in general for colorectal cancer screening, it's still about 90% are done by optical colonoscopy, and we're doing about 10% with VC or CT colonography. And of those CTC patients, the vast majority at our center are for screening. It's at least 90, 95%, I think around 95, which is obviously much different than pretty much any other center where the majority, I believe, are still by incomplete, for incomplete colonoscopy.
Right. And how many exams are you currently doing per year?
We've averaged over 1,000 per year. Admittedly, the volume has plateaued and even dropped off in the last 4 or 5 years, I think partly because of this the uphill battle of just winning this public perception, with the guidelines not aligning. So it's been a bit of a struggle lately, but we're still overall averaging about 1,000 per year.
Oh, great. So Perry, tell us a little bit more about the study now. What was actually the motivation for your study? What kind of drove it? It looks like a lot of work. People have been talking about lesions that are missed on colonoscopy for quite a while. So what was going on as you decided to tackle this?
Well, you're right in that this was probably one of our more challenging studies. It was really over, a decade in the making. And we realized over time from the validation trials, we know that missed lesions, if they're not found at the initial colonoscopy in a validation trial, even with segmental unblinding, there's really no way to arbitrate or say that it was a colonoscopy miss. You simply don't have the follow-up that's needed. So even though we showed initially at validation that over 10% of large polyps might be missed at colonoscopy, even when they know or whether or not they know the CT findings, CTC findings, we had no real evidence in terms of what happens with those lesions that are discordant. That is, we call a lesion at CTC and they don't find it at colonoscopy, even though they're unblinded. So that was sort of something that can't be accomplished in a sort of artificial validation trial and really requires our actual clinical practice experience. So admittedly, though, this takes many years to develop. What we do and what we've always done is for every discordant lesion, we have 2 radiologists, CTC readers who didn't read the initial exam, review the study and come up with a game plan, basically putting it in a category of likely CTC false positive, in which case we don't pursue it further, or if it's a potential miss at colonoscopy or a false negative on their part, then we push a little further and we need to hopefully do a follow-up CTC depending on the size of the lesion, the location, that would obviously impact when the follow-up gets done. In some cases, the patient went straight to colonoscopy at a follow-up date, but we really prefer the CTC to reconfirm those findings with the fear that if they miss it again at colonoscopy without an additional CTC, they might continue to think it's a false positive. So long story short, it's it was a very important study, but it's important to really understand what this means beyond all the validation trials.
Sure. Now, there's a lot of numbers in the paper, but ultimately over 9,000 exams were looked at, and there were 180 unconfirmed polyps, and 66 of these at the initial re-review were not felt to be lesions. And I wonder, what did you think these were? So most of those cases, and I don't have the exact numbers offhand, but a lot of those cases involve patients with other obvious lesions. So these were maybe a second, third, or fourth positive finding, in which case
they were soft calls, if you will. They might be possibly adherent, poorly tagged stool. We always use contrast tagging, so that's actually a very uncommon cause of a false positive. But there are cases of thickened folds, poor distension, maybe causing a pseudo-lesion, and other less common things. But even some of these, of course, we feel may have, in fact, been true lesions, but we're below our threshold to push for another exam because it's asking a lot to have a patient redo an examination. So in some cases, if it was close to the 5 to 6 millimeter size threshold, we might have just called it a false positive, even though there may be an outside chance of a true lesion. It's a complex group of false positives.
So the quality of the prep and the feces was not kind of the most common source. I think that's kind of an important thing because most people would think that was where you're going to get hung up.
Yeah, again, that actually is an important subset. So although we have our prep is very robust, if patients don't follow the instructions, there are certainly cases where we just simply can't exclude a true lesion amongst a sea of residual stool. It is an important point, even in our practice. That's not uncommon.
Now, the heart of the paper, at least from my perspective, was 31 out of 144 lesions were colonoscopy false negative on re-examination. That's really the heart of what you're reporting. And can you tell us what type of lesions were these? Where were they located?
Sure. And to clarify a little further, those lesions that you're talking about, the 31 false negatives, was out of 78 discordant lesions where we felt there was the need and we did get follow-up. So we can only really talk about those. So actually that's 40% of cases where we thought it was potentially a false positive and went on to further testing. So, a little less than half proved to be true lesions. And interestingly, the vast majority of those, I believe 80% of those that were found and resected were neoplastic, meaning they were some sort of adenoma, a serrated lesion, and even more importantly, of the advanced histology, the advanced neoplasia, 90% of those were located in the right colon, which we're really starting to recognize that CTC has definite advantages for right colonic evaluation compared to physical endoscopy, where there's limitations just due to the distance and the looking behind folds, etc. So I think that's really a take-home point: is that most of these, the vast majority of these, are potentially precancerous, and that most of the very important ones are right-sided. So we have a complementary role, I think, in detection with CTC and colonoscopy.
Yeah, you may or may not know that I used to do a lot of barium work early in my career, and when we looked at this with double contrast, the right colon was probably the most common by far, again, tucked behind folds, and they can't flex the scope back enough. And the other place, surprisingly, was right at the rectum, where, again, they have to flex back to look frequently, and if they don't do it right, there are some blind spots. So those locations are important. Now, one thing that was kind of striking to me, I was surprised that most of them were sessile or polypoid lesions rather than these very flat lesions. You had some serrated lesions, and I would have suspected that the flat lesions, which you are detecting at CT colonography, would be the ones missed. Any thoughts about, were you surprised at that, or they're just so uncommon?
Well, yeah, that's an interesting question. We are certainly finding more and more flat lesions. In fact, we recently will have some upcoming data on our serrated detection. Because these flat lesions coat with contrast, we think the dilute barium, that is increasing our detection rate for these. My concern is that when we do have a discordant flat lesion, that either on review we're calling those likely false positives because they are often quite subtle, and also that they're being missed on repeated colonoscopy as another option. But I could be, in the back of my mind, I'm also thinking too that most truly discordant lesions are probably in that flat range, but we just don't have a good handle on how to correlate those, how to confirm those, and they remain a definite challenge.
Yeah,
but I think our detection rate for both is improving.
Yeah, I think that my impression is that is another non-geographic blind spot. And the Japanese, of course, use these vital dyes to bring out those subtle surface pattern changes to help the detection of these lesions. And they're still not done widely in the U.S., so it's perhaps something to look at in the future. So were you surprised at the findings of your study?
Well, not really. Over time, we as we've accumulated our clinical knowledge of this and see the false negatives coming out year after year, I was hopeful that the results would be in this sort of ballpark. Of course, to actually sit down and execute the study was a whole other level of challenge. And I'd like to acknowledge Dustin Pooler, one of our residents who's done a lot of CTC research with us, and he really painstakingly tried to follow up all these lesions. But no, I guess I'm not surprised only because of our unique experience in dealing with these year after year. But I hope this sort of I hope the gist of what we're reporting comes through, and that colonoscopy is clearly not an infallible gold standard. There are complementary nature to CTC and colonoscopy, and we're certainly not trying to denigrate, colonoscopy, which is the therapeutic gold standard, of course. But I think we still have a lot to learn in how we can help each other and reduce the overall cancer risk by putting these studies together.
Sure. What's been the impact of your findings? Has it affected how patients with unconfirmed polyps of CTC are now managed? Were the gastroenterologists surprised at the findings?
Yes, I'd have to say I think they were. It was a bit of one more level of awakening. I think the first time we reported our results back in the trial days, I think they were surprised that their miss rates are essentially doubled for large adenomas. Now we're adding a whole other layer of misses that are only found at subsequent evaluation. So I think they're finally believing us when we tell them with the discordant lesion, where we think there's a legitimate chance that something was missed for geographic reasons, as you've noted, or morphology reasons. And that it's worthwhile to not only repeat examination, but do that by doing the CTC first with same-day colonoscopy to follow if we reconfirm that lesion. If we have a very high confidence and good reason for a miss, we'll go straight to colonoscopy. But I think our endoscopists are now on board with this sort of line of reasoning, whereas initially they either would just dismiss it outright, or maybe do a repeat colonoscopy, not see it again, and we'd still be in the dark. So it has really helped in that area of confusion.
Good. Thank you very much. Before we end, I want to get to sort of the money shot. Where are we now in terms of having broadly reimbursable CT colonography services available in the United States?
It's a mixed picture, really. We've made significant strides with some of the private insurers, I think, and that's not well appreciated. I think the degree of coverage that's already out there is just not well advertised, or there's a lack of awareness. But the big issue, of course, whether it's symbolic or not, is to have Medicare coverage, even though that's 65 and older generally, and we're going for 50 and over. I think we really need that level, that blessing from both the U.S. Preventive Services Task Force and CMS. I think we'll have it from CMS as long as the picture becomes more clear from the USPSTF. And unfortunately, that got further muddied in the sense that they may not be individually grading these tests, rather putting them in primary and alternative listings, which is causing a lot of confusion, and we'll know probably within a few months as to whether or not we were successful in alerting them to this potential confusion. So stay tuned.
Well, good luck, and thank you very much for this very informative discussion. I want to thank you for joining us.
Thank you. I appreciate it.
Hi, this is Debbie Levine. I'm the Senior Deputy Editor for Radiology, and I'm here today talking with some of my co-scientists about an interesting study on digital compared to screen film mammography, measures of diagnostic accuracy among women screened in the Ontario Breast Screening Program that's going to be published in the February issue of Radiology. And I have with me here Megan Prummel, who's an MPH and Senior Research Associate from Cancer Care Centre, Ontario. So welcome, Megan. And I also have Anna Chiarelli, who is a PhD and Senior Scientist, Cancer Care Ontario, and Professor, Dalla Lana School of Public Health, University of Toronto. So welcome, Anna. And then I also have Dr. Etta Pisano, who's the Vice Chair for Research at Beth Israel Deaconess Medical Center, and who wrote an editorial on this article. And we felt that this was sufficiently important topic to warrant an editorial, and sincerely thank Dr. Pisano for writing it. So welcome, Etta.
Thank you. Happy to be here.
So this really was an interesting study, and I think it's quite important. I'm wondering, Megan, if you can just tell us a little bit about what you did and what you found.
Sure. So this was an observational cohort design study. We examined women who were screened in the Ontario Breast Screening Program from 2008 to 2009 and who are aged 50 to 74. And we followed these women forward for 2 years, which is the standard interval in the Ontario Breast Screening Program, to ascertain whether they had been diagnosed with a breast cancer. We further identified 3 different cohorts based on the type of mammography that a woman was screened with. So there were 3 types that we looked at: digital mammography with computed radiography, digital mammography with direct radiography, and screen film mammography. So the major differences between these types are that for screen film mammography, which is sort of the standard type before digital mammography was introduced, it's an image that is produced on a film, and a radiologist would view it on hard copy on a film view box. Digital mammography is viewed on a computer screen. For computed radiography type, the image is recorded on a cassette and is removed and viewed on an external reading device. Whereas for the direct radiography type, the detector is part of the imaging unit. So when the image is recorded, it's viewed in real time. So our major interest for this study was to look at the integral cancer rate and sensitivity and specificity of each of the different screening modalities. And we compared direct radiography and computed radiography to the standard at the time, which is screen film mammography. What we found is that for computed radiography, the sensitivity was significantly lower than for screen film mammography, and we also found that integral cancer rate was substantially higher, though that result was not statistically significant. And for DR, conversely, we found, or direct radiography, we found that the integral cancer rate and sensitivity were similar to screen film mammography, while the specificity was somewhat lower.
So, Anna, it's clear that you were not surprised so much by your results, since the computed radiography has physical limitations that you nicely document in your study. And your group also had a piece on screening mammography and assessing CR specificity previously. It was, personally for me, the 38% difference in sensitivity between modalities that I found so astounding. And I was wondering if you were surprised at this level of difference found in your results.
Yes, we were surprised. So the earlier study actually didn't look, it looked at cancer detection rate. So the first study that was published and I think it was the only study that had found this at the time, was it found a 20% lower cancer detection rate for computed radiography compared to screen film mammography. So we had expected that the sensitivity would be lower, but you're right, it was greater than we had expected, and no other study to our knowledge, has published differences in sensitivity for computed radiography versus screen film mammography. They've only looked at specificity.
Right. So one criticism of your study might be, well, this is coming a bit late. This is old technology and computed radiography is on the way out. So I'm just wondering, is it ever too late for this type of finding? Or should we apply similar concerns to other technology in use today?
Well, I believe that computer radiography may still be used, so I think it's important to look at these results. And in fact, when our earlier results came out, which was about 2 years ago, and we found the lower cancer detection rate, at that point in Ontario, we did actually transition all of the machines that were computed radiography to direct radiography, given that evidence at the time. So we didn't wait until we looked further into the sensitivity. We felt that data was enough at that point to make the transition. But since then, as I said, at that point there was really no clinical evidence that computed radiography was different than direct radiography. Although, like you had said, I think there had been the physics had shown some differences, but there was no clinical evidence to that effect. So I believe that it's important and in fact, it's also interesting because, sometimes you need a sufficient sample size to look at this, and I think our study was one of the first to have the sample size, and as well we looked at cohorts screened in the same time period, so concurrent cohorts. So sometimes designs of studies are different, and some earlier results may not show the differences. So I think it's important that even though, because as I said, until the study was done, it didn't seem that there was any difference in computed radiography. And I felt that we still had to continue to see further, even though we knew there was a lower cancer detection rate, whether or not accuracy was also different.
Okay, well, thank you. So, Etta, you wrote a very nice editorial to accompany this article, and I'm wondering if you could tell us a bit about your thoughts.
Well, I agree with what was just said, that it's not too late to study this topic. There's still a lot of CR systems, computer radiography systems, in clinical use in the United States and probably worldwide. Sometimes we get a very North American-centric view of the world, but in fact, with the cost of digital mammography and tomosynthesis being as high as they are, many places in the U.S. are still using CR. I don't know about Canada, but in the U.S. there are still places using CR, and I think around the world, maybe even a higher percentage of places are using CR. So I believe this is definitely a timely article, and I believe that the Breast Cancer Surveillance Consortium data could be analyzed to evaluate this exact issue in the U.S.
And again, that would be worth the time and expense because you think it would end up changing the way that we evaluate studies, or we could actually mandate that CR, if that were to be replicated, would no longer be used?
Well, I actually have a question about whether, this was a large study and very well done study, but, every clinical practice is slightly different, and it wasn't a randomized trial. It was an observational retrospective cohort study, a very well done study. But each practice and each radiologist should look at their own data and figure out if their cancer detection rates are lagging. It's possible that especially with the differences in screening in the United States, we don't screen every 2 years, we screen every year, that there are practices that are performing up to standards for computer radiography. And so that's why I believe, every center, every radiologist really does need to evaluate his or her own data before we generalize too broadly about this. It's possible that there are centers performing at appropriate standards with CR.
So if we see something that gives an added benefit to mammography, and if we assume that CR is actually doing the opposite. It's giving a negative benefit or making it a little bit more difficult. When do you get to the point where you think we should advocate for replacing new units? Because there always seems to be something new on the horizon, and if we keep on waiting for something new, we'll never replace our old machines, and yet once we buy something, it's already on its way out for the technology. So Etta, I'm just wondering, because I know you have a large amount of interest in tomosynthesis, when do we make that decision that we shouldn't be using older machines?
Well, right now, we're in the midst of a big controversy about screening in general. And, as you know, the main issue is whether we're overdiagnosing low acuity or things that are not going to kill women. And so it becomes very complicated. And that is exactly why I'm saying that individual centers need to look at their own data and assess their own performance. Because, you have to look at your own population. That's another issue with the Canadian data. Their demographics are substantially different than the demographics in the United States and may explain, the sensitivity was lower than one sees with the Breast Cancer Surveillance Consortium data. And so there are a couple reasons for that. One is, probably the screening interval had an impact. Canada screens every 2 years. We screen every year. The demographics of the population may be a point as well. We know that, our African-American population of more rapidly growing breast cancers and there is a small percentage of African Americans, a smaller percentage in Canada. So it may be that, and I don't want to sound too skeptical about these results. I actually really believe these results, and I believe they're due to exactly what was said in the article, that it's about the physics of the detector. But screening is such a complicated process that to generalize to a different population and to a different screening paradigm is a little bit dangerous. And so that's why I'm actually hesitant to be too aggressively suggesting that all of the centers in the United States should go to a different system. I actually believe that it's because we're doing screening, not just diagnosis, not just kind of the stuff that the rest of radiology does, we have to be cautious about adopting new technologies. We may end up doing more harm than good. And I sound like a screening skeptic. I am not a screening skeptic, but I have become more comfortable worrying about the paradigm of screening and what we do when we find things, how much harm we're doing.
I think that's a very good point. So, Megan, I'd like to draw you back into the conversation. We always are concerned about retrospective studies and study design and the biases inherent in them, and we've mentioned a few of the issues that come up with that. But I wonder if you would like to mention any limitations that you see in your own study design that we should be careful of if, for example, we design something similar to do in the United States.
Sure. So, with respect to our study design, despite the fact that we were looking at this retrospectively, we did do a concurrent cohort study. So all of the women that were screened in our study were screened during the same time period from 2008 to 2009. And some of the limitations to previous studies that we've observed are that the cohorts are designed in different time periods. So the study might be looking at a historical screen film mammography cohort compared to a more recent digital mammography cohort. So we would highly recommend that any observational cohort study be designed using the same time period for the women screened in the study. I don't believe that we had, despite the fact that it wasn't a randomized study, we did look at the patient differences between the cohorts, and there weren't any major differences that were alarming to us. So that's also something to be cautious about, and to look at baseline differences in the cohorts before interpreting the results.
And Anna, do you want to add anything to that?
Well, I guess too, also, you just have to be careful about multiple comparisons, and I think we did comment on that. So when you're doing, because we did a lot of stratified analyses, and sometimes things are significant just because of that. So to kind of be careful of that, and also, I guess, sample size. So I think our study was quite large, and that's very important. And especially if you wanted, like for sensitivity, you want to look at not only screen-detected cancers, but interval cancers, and those that normally are rare, and there's a smaller number. So therefore, you would need a large cohort, very large cohort, to look at interval cancers. And also, I'm not sure what the proportion of machines are that are computed radiography in the U.S., but in Ontario, it was 25% of the machines. So again, you want to make sure you have enough numbers for these comparison groups, otherwise you may not see differences. Those are a couple of things.
And then Etta, you had mentioned obviously screening interval and patient population itself as being different between our two countries. What other factors do you think we should consider?
I think just the reading. I think that we are pretty comfortable that Canadians and U.S. radiologists read very similarly. When you compare the data of the sensitivity, specificity, cancer detection rates, allowing for difference in screening interval, you really do see a very similar pattern of callbacks and things like that. So I believe this really does apply to American radiologists in a very direct way. And so I don't have concerns about that. And I agree with the comments about the size of the study and the populations. The only real differences I see that worry me a little in terms of whether it's generalizable to the United States is the screening interval and the demographics of the population. And as I said, I think the Breast Cancer Surveillance Consortium, even though they have limited funding at this point, they probably could do a similar study pretty easily and publish it, and we'd have an answer.
Terrific. And then Anna, Etta previously kind of alluded to this. When we look at sensitivities of different modalities, it's possible that just having increased sensitivity is not enough, that we might be finding something like low-grade DCIS, and thus the enhanced sensitivity is contributing to the so-called overdiagnosis. Are there particular morphologies or histologies whose detection is either enhanced or maybe deterred by different imaging methods?
So in this study, the majority of the cancers were invasive cancers, and it was about 80%. I think 20% were DCIS. Within the DCIS, we weren't able to look at the grade. We didn't have the information on the grade of the DCIS, but the sensitivity, although it wasn't significantly different, it was similar to what it was for the invasive when we did the stratified analysis. So in that case, but that was the only information that we had for this study, was whether or not it was invasive or DCIS.
It would be interesting to know if the cancers were ER, PR positive, HER2 overexpressed, those kinds of things. And are you planning to do anything like that?
So actually we do have a study that's been published in Breast Cancer Research and Treatment on the prognostic features of cancers detected among women in this study. And so we actually found that for computed radiography, the cancers that were detected at a later stage. And we did look at ER/PR receptor positivity, but we didn't find any significant differences there. But I encourage you to look at the paper to follow up on more of those differences.
It would be nice to know about the ER/PR negative cancers, because those are so if it's ER/PR positive, HER2 negative, and those are detected later, those may not matter to the woman's prognosis, but if the ER/PR negative, HER2 positive cancers are being detected later, that's a very significant, worrisome result. So that would be an interesting thing to look at. And if it's in the paper, I'll find it. But you don't remember, I guess, right now whether...
Off the top of my head, I don't, but I do know that we had much lower sample size, especially for CR cancers because of the smaller cohort. So I'm not sure if we would have been able to look at the stage of ER/PR positive, HER2 negative cancers specifically, but definitely something to follow up on.
Yeah, I think that's a good point. So we've been kind of looking backwards in time, talking about computed radiography, and I'd now like to look forward, because I know, Etta, you are very interested in imaging tomosynthesis and research on that. And so if we know something works better, and I think we're all going to agree that tomosynthesis definitely works better, at what level of evidence do we need to guide clinical decision-making and perhaps even to direct policy changes for breast cancer screening?
So, when you say tomo works better, we know it has a higher sensitivity, finds more cancers, and it has a reduced callback rate. I think the issue among the skeptics is, again, are we finding things, are we getting to the point where we find things that don't affect patient outcome? And so that's the threshold. We have to prove that we're affecting patient survival or patient morbidity. We have to, we can't just use radiology endpoints to affect national policy. We have to actually show patient-centered outcomes that are improved. And so that's why you haven't seen that, and the cost of TOMO is why you haven't seen a gigantic rush to TOMO. I think that there's enough debate right now about what we're finding. That's why I asked the question about the serotypes of the cancer, if you will, because we know that the ER negative, PR negative, HER2 positive cancers, or just HER2 positive, no matter whether ER and PR are positive or negative or not, those cancers are the bad actors. They're the ones that kill women. Now, there are some DCISs, there are some, I don't want to make it sound like it never happens,
Right.
but those are the ones that in general really hurt women. And so we're now being pressed by the epidemiologic and scientific community to do something besides show improved sensitivity and reduced callbacks. Those are radiology outcomes. We need to think of public health outcomes as our most important outcome measures.
And yet, if you want to do that kind of study, and I know that you are attempting to do that kind of study, it's immensely expensive because you need to screen so many women to find the cancers, to have enough cancers, to be able to do the kinds of analysis you want to do on the subtype of cancer, and then show outcome differences.
Yeah, it's going to be a big study, but I would say it's probably one of the most important public health issues facing us today. We can't keep telling women we don't know whether they should be screened or not and how frequently they should be getting screened. I mean, they are hearing very conflicting advice right now, and it's worth, in my view, spending $100 million over a 10-year period to answer that question and to have better data on that. The NCI's annual budget is $5 billion, annual budget. So if we spend $100 million over a 10-year period, that's a very small percentage of what they spend, and it will answer the study that, TMIS that we're proposing. In fact, it's already opened in Toronto, the study, but because we had some money from the Breast Cancer Foundation of Canada, or the Canadian Breast Cancer Foundation. That organization has started the study in Canada, and we can answer the question, and it's going to have a major public health impact. So I would say tomosynthesis, from a radiologist perspective is better, but from a public health perspective, the jury's still out.
Well, it's been wonderful to talk with the three of you today. I am just so impressed with the research that all of you do. It's wonderful when I get papers like these to read because I find them interesting and clinically important right away. And that's just wonderful. And so I want to thank you for your time and for being here with me.
Thank you.
Thank you.
Thank you. I enjoyed it.
Thank you.
Good morning. It is my pleasure today to introduce two papers from radiology that will be published in February 2016. And those two papers comes to us from Dr. Wu, who is from the University Hospital of Taiwan in Taipei, Taiwan. And the title of this paper is Elasticity of Coracohumeral Ligament in Patient with Adhesive Capsulitis of the Shoulder. And the second paper is from University Hospital of Zurich in Switzerland. And this paper is by Dr. Roskopf and colleague. And the title of the paper is Quantitative Shear Wave Ultrasound Elastography of the Supraspinatus Muscle. And this is for about reliability of method, relation to tendon integrity and muscle quality. So good morning, both of you, Dr. Roskopf from Zurich and Dr. Wu from Taipei, Taiwan. Happy New Year. good night for you. Happy New Year. And I will start actually my discussion here by asking Dr. Wu, what prompted you to do your study?
Thank you. My study is focused on adhesive capsulitis of the shoulder, and also known as frozen shoulder. And it is characterized by loss of glenohumeral motion. And in clinical practice, we treat it with oral medication, physical therapy, or ultrasound-guided intra-articular injection of steroid. And this method may reduce pain and improve shoulder range of motion, especially anterior flexion. However, external rotation usually remains restricted. And because it limits the patient's ability to do some activities of daily living, such as hair washing or dressing. And from textbook, we know that the coracohumeral ligament is the main restraint of shoulder external rotation. And previous studies using ultrasound or MR imaging have shown that a thickened CHL, coracohumeral ligament, is associated with frozen shoulder. And it has been proposed that a tightened coracohumeral ligament may restrict external rotation in patients with frozen shoulder. But a comparison of the elasticity of the coracohumeral ligament in frozen shoulder patients has never been conducted. Therefore, we are interested in this and conduct. So that's why we conduct this study.
And why do you think this is important? Why the knowledge of, the elasticity is important at this point?
Yes, because
implication in treatment, for example.
Yeah, previous treatment focused on the whole joint capsule. For example, hydrodissection or intra-articular steroid injection. But in our experience, the external rotation is rarely treated by this conventional therapy. We want to know what is the role of the coracohumeral ligament in these patients. Maybe we can do some intervention to the coracohumeral ligament to make the patients have better external rotation. Yeah, that's what we think. Yeah.
Thank you, Dr. Wu. I'm going to turn to Dr. Roscoff and ask her the same question. So why did you do this study?
Yeah, we wanted to evaluate the shear wave ultrasound elastography in the rotator cuff because up to now there are no data available using our ultrasound machine with this technique. And we thought that this technique could add important information to assess muscle quality. Because up to now, radiologists only talk about the fatty muscle infiltration in the rotator cuff and about muscle volume atrophy. But we think that the muscle stiffness can also add important information for assessment of the rotator cuff muscles. Because we know that our surgeons, when they operate on patients with rotator cuff tears with full retraction, they have difficulties when they want to reattach tendon muscle unit that is really stiff. So in these patients, it can be very helpful for evaluation of the muscle tissue preoperatively.
So you think the stiffness would be clinically or arthroscopically related to what you see on or correlated with what you see in shear wave elastography?
This can be, of course, we have no proof yet, but this can be an interesting topic for the future.
Okay. Dr. Wu, I come back to you, and I want to just say that adhesive capsulitis, as you introduced, is a clinical diagnosis. So my question would be, what is the add value of your shear wave elastography measurements to the clinical diagnosis itself, or simply to the ultrasound, conventional ultrasound?
For diagnosis, that's just my opinion. Let me explain our study's results in briefly. Imagine the coracohumeral ligament as this rubber band, and it is normal and it is thin. So we can easily stretch it. Okay, but in the frozen shoulder patients, the coracohumeral ligament is thicker and also very tightly, so we cannot stretch it easily. So we hypothesize that maybe we can target this ligament in those patients who cannot do external rotation easily. For example, doing steroid injection just into the coracohumeral ligament.
Okay, that's actually a good point. And if I turn now to a Dr. Roscoff, I found actually your data a little bit intriguing. And actually, as a conclusion, you concluded that the findings of the study showed here the shear wave tends to decrease with the increase of infiltration. And that's for Guattari 1 to 3. But when it comes to Guattari 4, which is a huge, the severe fatty infiltration of the supraspinatus, then your actually shear wave results will re-increase. Can you just tell us a little bit about, what happened here?
Yeah, normally you would expect that with increasing fatty infiltration, your shear wave velocities would drop. So you would have the most decreased values in Guattari stage 4, but that is not what we found. We don't really know why we found these measurements, but one explanation could be that the fatty infiltration Guattari 4 we found in patients with full thickness tears with a full retraction of the supraspinatus muscle. And it is known from animal studies, if you detach a muscle, then first your stiffness in the muscle decreases in the days after the detachment. But then after a few weeks, 8 to 16 weeks, it's known that the stiffness re-increases in this muscle. So perhaps our measured patients, they were detached for a longer time. And that could be an explanation why we measured higher values in these patients.
Okay, if I go back actually to the practical measurements here, Dr. Wu, can you tell us a little bit about the time needed for the shear wave elastography to be performed?
You mean the learning curve, right?
I will say yes. Learning curve is a very good, actually, an interesting question, and also what time you add for the ultrasound, conventional ultrasound, to measure that shear wave elastography of the coracohumeral ligament. Is it 1 minute? Is it 2 minutes?
Actually, the measurement of the elasticity of the coracohumeral ligament is very difficult. Yeah, to be honest, I spent about 30 minutes for one patient. Because the first coracohumeral ligament is difficult to identify.
True.
Yeah, and we need to do internal rotation and external rotation to confirm the upper border and the lower border of the coracohumeral ligament. And also because we use the supersonic shear imaging, and the elastography on the machine is it changed in real time. So we have to wait until the image become very stable, and then we take the picture. Yeah, so it takes a lot of time, and it needs actually needs practice.
So what is actually the time for practice, as you said? What is the time needed to be a good shear wave ultrasonographer?
I cannot say I'm a good elastographer. Yeah, but to obtain optimal image, actually I practice on almost 30 to 40 patients.
Okay.
After that, I am confident that my image quality is good. Yeah, so it's a long time.
Thank you. Dr. Roscoff, how about you? That measurement of the elastography of the shear wave elastography of the supraspinatus muscle?
Yeah, I think the time you need for the elastography depends on the tissue that you want to assess. Because if you want to assess a whole muscle, so it's really easy to put a probe on the supraspinatus muscle. and you can do the elastography in about 2 to 3 minutes. That's not a problem. But I think if you have such a small ligament as the coracohumeral ligament, it can be really difficult to find and to do it.
Okay, my question to you both, because I thought that it would be much more easy, to be honest. But let's say now we have one of you is in Zurich and the other one is in Taipei, and I'm actually sitting here in Boston. If I want to just do this, do you think there would be a difference between machines that we use in different countries, or different machines, different brands? There would be different results here, or you think the results would be the same? I will give it actually to Dr. Wu to answer, and then you, Dr. Roscoe.
It's a good question. Actually, in our hospital, we have only supersonic shear imaging, and the Siemens Acusen S2000. That's an older one. So actually, for the Acusen S2000, the region of interest on the elastography on the VTI and VTQ is too big for a ligament. So in my own experience, we can only use the supersonic shear imaging. Yeah, but I don't have experience on the Acusen S3000, so maybe we should ask Professor.
What do you think, Dr. Roscoe?
I think from published data, it's known that the absolute values of your shear wave velocity are different from one manufacturer to the other. So you can only compare measurements if you have the same ultrasound machine. And there are some other factors that can influence your measurements. For example, the orientation of your transducer. So for muscle tissue, it's important that you align it parallel to the long axis of the muscle fibers, because then you get other values than if you would turn them perpendicular to the muscle fibers. It is known that measurements are dependent of your position. So for example, if you have a normal position of the shoulder or the arm, you get other values than if you do a 90-degree abduction. And furthermore, shear wave elastography velocity is dependent on the depth of the assessed tissue. So if you have a muscle lying very deep, you get lower shear wave velocities than in more superficial tissue. And it is also known that it's dependent on the age of the patient. For example, for supraspinatus muscle, it's known that with increasing age, your muscle stiffness decreases. So, and that's one point why we tried to match our patients with volunteers of the same age and same gender, because these factors can all influence your measurements.
So the reality, these two papers relates to ultrasound shear wave elastography measurements in the shoulder, one of them on coracohumeral ligament, the other one in supraspinatus elasticity. So from this point of view, Dr. Wu, how do you think these two papers, the results of these two papers relate to each other, in your opinion?
In my opinion. In frozen shoulder, usually in primary frozen shoulder, the supraspinatus tendon should be normal. Yeah, it is disease of joint capsule. And because I don't have too much experience on the muscles, so actually I cannot answer this question.
Yeah, how about actually you, Dr. Roscoe? Do you think there is actually any relationship in you using actually those results together? The two papers here?
I think both try to add some information that cannot be found if you only do B-mode ultrasound. So they try to assess stiffness of a tissue, and you cannot do it with another imaging modality with ultrasound up to now. So that's the strength of the papers.
Let me know. Just give a general impression here. So we have these results. They are there. With actually communicating with you in this absolutely nice conversation, I can see that it's not easy. Very honestly, I do think myself, I don't do this elastography as a matter of fact, with convection ultrasound in my department. But let's say it looks like it's a little bit difficult to apply it, but I do think myself, it's a great venue for research and for, again, for clinical practice. So I want to just ask you, Dr. Roskopf, what do you think the next step in clinical practice and in research to bring to the T-wave elastography as a, I would say, as an additional measurement to conventional ultrasound?
Of course, we have to do research with some more patients and a bigger study population. But I think the problem, if you want to compare the different study papers, is that they are not consistent, because some researchers, they only publish the shear modulus in kilopascal, and the others only publish the shear wave velocity in meters per second, and that it's really, really difficult to compare the results. So I think we have to find some kind of consistency. What do we report in our studies?
Well, thank you very much. I do think it was a very interesting, actually, kind of conversation, and I want to just, again, thank you because of the time difference for joining us this morning, and I hope that you'll find this discussion very interesting. Thank you.
Thank you.
Thank you.